Okay, tonight we have Dr. Deanna Gerber with us. She is a gynecological oncologist at NYU's Perlmutter Cancer Center on Long Island. She is also a recent breast cancer survivor and a BRCA1 mutation carrier. Her passion is to provide humanistic care to her patients, pulling from her own experience as a survivor. Dr. Gerber's the title of it is Post Traumatic Growth in Cancer Survivorship. And I can't even tell you how excited I am for this because I know Dr. Gerber and I spoke a few weeks ago, and she just has a wealth of knowledge, obviously as a physician, but going through cancer just takes it to a whole other level. So I'm very excited to listen. So I'm going to take the pin off of me, and if you would like to share your screen, you can go ahead.
Sure. All right. And then I'm going to. Okay, and now I need to new share. Bam, portion of screen. Okay,
Okay, looks good.
great. Thank you. Let me make it a little bit smaller. Look at this. Sorry, just getting set up. All right. So Jen, thank you for the introduction. I'm really excited to be sharing with you guys. You seem like a very lovely group of people and really motivated to kind of learn more about, cancer survivorship and how to, how we can best care for yourself and care for each other. And so this is the perfect audience. And again, so my talk is called Post-Traumatic Growth in Cancer Survivorship. So I know Jen already gave you my credentials, but I just want to go through them briefly. I know it's going to sound like I'm bragging, but that's not my point at all. And so I knew I wanted to be a doctor from, I think straight out of the womb. I have my bachelor's in science. I got I majored in neuroscience and then went on to get a master's degree in neuroscience as well, at Tulane University in New Orleans. And then didn't apply to med school yet, but did a job in a lab researching rare diseases where I did surgery on mice and rats, and it was all fun. In 2012, I graduated from med school. And in med school, I always knew I'd wanted to do women's health. And so I focused on OBGYN. And so I then went and matched at my top program for residency at New York Presbyterian Cornell and I finished that in 2016, then went on to do an extra 3 years in gynecologic oncology, so cancer care in women's reproductive tract. And I finished that at NYU in 2019. And, since then I've been working at NYU. Not only that, but I've presented research at conferences. I've, published in notable publications. And so one might think that I am an expert. And even in my free time, I read cancer journals because I just love the field so much. But even with all that, I like to think that my actual training in oncology didn't really even start until January of 2021, when I was diagnosed with stage 3 triple negative breast cancer. So this is me at the infusion center of NYU, where I work as an oncologist, and now as a patient on the other side of things. And so since then, I've gone through 20 weeks of chemo, 6 weeks of radiation, 3 major operations, weekly visits with my therapist, acupuncture, joy, heartbreak, and I'm currently in remission, and I'm very grateful for that. I've experienced so much love and support from my friends and my family and my medical team and my colleagues. And I've seen all of my knowledge be put to use firsthand. I've also grown immensely as a person and as a physician during this time, but it was all against my will. There are some things that I noticed very early on. There's definite gaps in my training. I noticed that from the outset, from day one, the way we talk to our patients, the way we deliver bad news. And so it's kind of been my passion, my purpose to elucidate some of these things. There's just a bunch of stuff that you can't fully know until you're going through it yourself. And so I would like to, earnestly and humbly share my opinions and thoughts on some topics that are really, salient for cancer survivors. I will discuss scientific data to support everything, but it will all be through my own personal lens. So today's objectives will be to discuss the phases of survivorship, to understand cancer as a type of trauma, to outline ways to help get through this inevitability, to define post-traumatic growth, and to explore ways to enhance post-traumatic growth. So the American Cancer Society estimates that there's approximately 18 million people in the United States that are current cancer survivors. This is going to get worse, and that's for many reasons. One is that certain cancer, the rates are continuously rising. Another reason there's more survivors is because our treatments are getting better. So we're curing more people, we're getting more people into remission, we're getting more people into maintenance phase. And so our surgical sciences, our chemotherapy agents are all doing better. Our research is working. And additionally, we have an aging population. So there's going to be more people alive at any time that have had cancer and are, considered survivors. So briefly, I just want to go over what does a survivor mean. I know the term survivor doesn't resonate with everyone. I've gotten feedback during other talks that some people don't like the term survivor. They don't like to be referred to as a survivor, but I will use that term during this talk because it's the generally accepted term in medical journals and medical terminology. And so these definitions here of survivorship phases are the ones given forth by the American Society of Clinical Oncology. Acute survivorship is the time from the day of diagnosis and then gets you through active treatment. Extended survivorship then includes the months right after treatment is completed, and then permanent survivorship is usually measured as the passage of time, often in years, after the cancer diagnosis. We know that not everyone can fit into one of these nice little boxes. We have people who are on maintenance medications, people who are thrivers with recurrence. And so this doesn't really capture it, but I think it's a good visualization. Also, I want to note that the term from the American Society of Cancer, the term survivor includes caregivers as well. So your main caregivers are also considered survivors. And I want to always give props to our caregivers and our support system. So this is my depiction of acute survivorship. Getting through active treatment to me felt like treading water. I was using all of my energy to try and stay alive and to make it to the next phase in active treatment. Society is going to help you out during this time. I had friends and family checking in on me daily. I was lucky and my job was very understanding, and they gave me time off to recover from my treatments, which in turn gave me time to rest, take daily naps, and I had plenty of time for self-care. I spent a lot of time seeking out different management options for side effects that I was experiencing. I had time to go get massages and try acupuncture and meditation. I was very lucky and very privileged in that regard. Another thing that we don't really talk about that often is that during that time, I looked sick. I lost my hair. I was pale from anemia from the cancer treatment, and I looked exactly how society depicts a sick person, a cancer patient. And with that comes society's willingness to accept that I probably can't do all the things that I was once well enough to do. So it comes with a built-in buffer. Another thing which we don't, often talk about and is often overlooked is the comfort of seeing your doctor all the time, seeing your doctor weekly or biweekly. Someone during active treatment is constantly telling you you're doing okay, everything's okay during a very anxiety-provoking time. And then active treatment ends and you're getting tired of treading water and your support system slowly fades away. Friends and family assume that you should be feeling better. You see your doctors much less all of a sudden, and your doctor hands you a packet of paper and says, "This is what to look out for. I'll see you in 3 months." But it was just weeks ago, days ago, where you were so sick where you were needing to see your doctor every week. And then your hair grows back and you don't look sick. And all of a sudden, everyone expects you to go back to normal. Work thinks you can come in at full speed. And so this is a poem that I had seen years ago that still really resonates. I never wanted the lifetime membership to Survivorship, yet here I am struggling to stay afloat on this effing life raft, while the others wave from their cruise ships and say, I thought you were fine now. I find it so powerful, and I think it really captures the essence of what we're trying to convey in this talk. So now what happens when we're supposed to, we're fine, we're on this life raft alone, your support system fades away, and we're supposed to go back to normal. Well, that's the $1 million question. What do we do now? And another more important question is, does this even matter, and why does it matter? I don't really know the answer to that. I obviously think yes. Before even having cancer myself, I was always a big advocate for supporting and talking about and destigmatizing mental health issues and bringing them to light. But alas, mental health is still considered a soft science. So besides even caring about mental health, are there other reasons why the medical community and society should care about what we're talking about today? I obviously feel that the answer is yes. And I, again, could talk about this for days on end, but we need to get people, we need to get society, we need to get policymakers, hospitals to listen and to really care. And to do that, we have to talk about the science behind it. So I'm briefly going to be talking about the science. No worries. So I briefly want to talk about the science, the chemistry behind this. Scientific research has shown that stress related to psychological factors influences the development and progression of cancer. Stress influences cancer cells growing. Stress can affect your immune system, which is absolutely vital to fighting cancer and to suppressing cancer. If stress is affecting your immune system, then several downstream processes are being affected as well. The duration of stress also matters. Prolonged exposure to stress can set off a chain reaction that can awaken dormant cancer cells, or cancer cells that have been suppressed in animals, in mice. We've shown this. And so this is why it matters. We need to figure out ways to manage stress, how to deal with stress. It matters scientifically. So what happens when you first get your diagnosis of cancer is you're routinely screened by your provider for depression and anxiety. It's usually a brief assessment of symptoms. This should then automatically trigger some sort of evaluation by a social worker or a mental health advocate who is part of your cancer care team. Sometimes this happens by the phone, or sometimes this happens in person. For me, it happened in the infusion center. And then a more comprehensive screening will happen. The reason why this all happens is because depression and anxiety are known to be very prevalent in people with cancer. Depression and anxiety affect up to 20 and 10% of people respectively. And this is in comparison to 5 and 7% of people in the general population with non-cancer. So tons of research has been done on this, and it's not just a mental health issue. It's not just that you're sad because your life just got flipped upside down. There are true biological components to this anxiety and depression as well. We know that certain cancers can actually release chemicals into your system that mimic symptoms of depression. We also know that certain drugs or medications that you're routinely given during cancer care can also cause depression symptoms. The most well-known one is steroids, oral or IV steroids. But, these mental health issues do not go away once the cancer is in remission or treatment is complete. And to me, that is the elephant in the room. So it's well regarded that having cancer is a traumatic event, but why does the medical community and society so infrequently regard it as such? This quote is from the book, The Body Keeps the Score. It's a book where they discuss healing from trauma, and the author then says, after trauma, the world is experienced with a different nervous system. The survivor's energy now becomes focused on suppressing inner chaos at the expense of some spontaneous involvement in their life. I bet that most survivors tuned in tonight can identify with this. But if cancer and cancer treatment are such a traumatic event, shouldn't we also discuss PTSD, or post-traumatic stress disorder? Surprisingly, or maybe unsurprisingly, little research has been done in this arena. So before we talk about PTSD and post-traumatic growth, we need to define the trauma. The DSM is kind of the Bible of psychiatric and mental disorders. It defines trauma as an event that imposes actual or threatened death, serious injury, or violence. So by definition, it's a bad experience, it's a negative experience, and according to the DSM, cancer would be included as a trauma. It's a seismic event that shakes your world and can shake your worldview. The other thing that trauma is known to be is a uniquely subjective experience. An event that is considered traumatic to one person may not be traumatic to another. I have a patient who's roughly my age and was diagnosed with an advanced cancer and doesn't seem to be, at all affected by it. And it kind of shocks me because I was so affected by my cancer when I was diagnosed. So it just goes to show that it's really, truly a subjective experience. Another thing about trauma is that it is an unexpected, uncontrollable, yet inevitable part of life. Cancer was added to the DSM as a stressor capable of causing PTSD somewhat recently. And this was important because it helped gain attention and foster research for the cause. Also, it has increased societal validation on the subject. But it has also been suggested that the experience of post-traumatic stress following cancer may be distinct from other types of trauma. In contrast to many other traumatic events, cancer is future-oriented with an internal source that makes it very hard to avoid symptoms related to the trauma. The patient has to continue going to hospital visits and follow-up tests. A further challenge is delineating the onset and termination of the traumatic event. The trauma can comprise all aspects of the workup, the diagnosis, the treatment, as well as the ongoing threat of possible recurrence. And it's all of these differences that indicate that the value in considering the post-traumatic reactions of cancer patients separately from other types of trauma. But again, if cancer diagnosis is traumatic, shouldn't there be more research on PTSD? So just to define PTSD in the cancer survivor, this is from the National Cancer Institute's website. It is an anxiety disorder that develops in reaction to physical injury or severe mental or emotional distress, such as military combat, violent assault, natural disaster, or other life-threatening events. Symptoms interfere with day-to-day living and include reliving the event in nightmares or flashbacks, avoiding people, places, and things connected to the event, feeling alone, and losing interest in daily activities, and having trouble concentrating and sleeping. The severe mental and emotional distress that cancer causes is the immense financial burden and debt that comes with cancer treatment in our country. The threat of dying, which continues long after the treatment ends, the loss of one's job after not being able to keep up at work, the loss of a partner or family member or friends because they didn't want to deal with you during your cancer diagnosis, the loss of your hair or your sex drive or your physical attributes, which help define your sense of identity. And the list can go on and on. I have to be honest that the reliving of the symptoms was hard for me when putting together this talk because it forces me to kind of sit down and relive it. But I feel so passionately about this that I'm overall very glad I did. So I was able to find two studies which focus on PTSD in the post-traumatic setting. There was one study which included over 400 patients with cancer. And what they found is that in that study, about 20% or a fifth of these patients had PTSD at their 6-month follow-up visit. And approximately 1/3 of those patients who were initially diagnosed with full PTSD at 6 months went on to develop chronic PTSD at their 4-year follow-up. In one other study of almost 500 participants who were diagnosed with PTSD, more than 1/3 of those patients initially diagnosed reported persistent or worsening symptoms at 5 years. So these are issues that may be affecting our population for a significant amount of time. Let's talk about this first. So it's been more than 40 years since the term ambiguous loss was coined, but this concept is relatively new to me and I wanted to share it. Ambiguous loss refers to the loss that occurs without closure or clear understanding. It is grief over a loss of what was, but also of what was meant to be in the future, now that your future has become unrecognizable. It's the kind of loss that leaves people searching for answers, which complicates and delays a process of grieving, and this can result in unresolved grief. The issue is complex when it comes to cancer survivors. The loss isn't always tangible or visible. I'm sure you've heard this before, but many people have said to me that I am still alive and, I should be happy. And yes, that is true, but it is painfully simplistic. There are generally two types of ambiguous loss that are talked about in the literature. And the second one is the one I want to focus on. It refers to a psychological loss, including a mental or emotional disappearance, like when somebody's personality changes so much that they no longer seem like the person you once knew. This is kind of like dementia would fall into this. This is considered a psychological absence with physical presence. You or your loved one is physically present, but changed, whether emotionally, cognitively, or both. And so this slide is used to elucidate how ambiguity may complicate healing. Many of you may be familiar with the Kubler-Ross stages of grief. That's the image down here. People who are grieving a loss go in and out of these stages in no particular order. But when you've experienced an ambiguous loss, you may be stuck in any one of these stages. This is sometimes referred to as frozen grief or grief limbo. It can feel like ongoing trauma because there is no answer and you're experiencing psychological ambiguous loss, and other people may not even realize that you're grieving at all. Ambiguous losses can feel isolating because they can be ignored, which make it difficult for the person experiencing loss. Cancer, as well as other chronic illnesses, put people in situations that seem to devalue their sense of self and keep them uncertain and struggling to understand their losses. The rest of the talk will be focused on, what we can do. So what's the solution? How can society and the medical community change this? We need survivorship programs that provide long-term and routine screening for PTSD. We need to recognize that this is a pervasive issue for survivors and their caregivers, and medical providers need to be aware so that we can try to do everything we can to decrease the financial and emotional burden during treatment and hopefully diminish this afterwards. We need to talk about this more and increase the discussion, hopefully to decrease the stigma around mental health issues in all people, especially in cancer survivors. And there are long-term side effects of treatment, which will have long-term implications on mental health. And so we definitely need to be talking about this. I've read many studies on the feeling of hopelessness with cancer, and most of these studies are performed during treatment. And I've spoken with many people in cancer support groups who echo my call for resources during the after the active treatment phase. We need more focused resources during all phases of survivorship. Cancer is a traumatic event, and we need to focus on supporting our patients and our friends and ourselves through this hard time. So this is a kind of segue into the talk as well. So how do we learn to cope? One measure of good mental health is the capacity to hold multiple truths simultaneously. For example, you can understand that opting for a hysterectomy is the wise choice, but you can also still grieve the loss of your womb. You can also know that you don't want your hair to fall out, but know that the chemotherapy makes your hair fall out is what's best for you. One feeling does not cancel the other out. Both feelings are true. This applies to so much of living with cancer, both during the months of treatment and in the later months and years of survivorship. Someone can feel absolutely reassured that they've had excellent treatment and are likely to stay well, but understand that this is never a promise, and we are focused to live with ambiguity. Some evidence-based interventions for dealing with this ambiguity include meaning-centered therapy, finding religion or spirituality. Other methods include attempts at reconstructing identity, normalizing ambivalence, and finding a way to feel gratitude or some sort of hope. Essentially, this is all to help stop looking for closure, because you may never find closure, and to stop longing for a life that was and to start focusing on a life that will be. Psychiatrists often have referred to a traumatic experience as a window of opportunity, and this may be just triggering for some people to hear. This is how I felt when I first heard that phrase, but bear with me. So when an individual encounters adversity, whether it's accidental or malicious, sudden or lingering, there are at least 4 potential outcomes that psychologists have proposed. One possibility is that there's a downward slide in which the initial detrimental effect is compounded and the person eventually succumbs or is defeated and does not really recover from that adverse event. A second possibility is that the individual survives, but in some diminished or impaired capacity. And then there are the two other options are resilience, which is a person may recover to their pre-trauma, pre-cancer state. And then there's this other fourth possibility of thriving. The thriving outcome has been studied extensively and is generally called post-traumatic growth. And we'll go into depth about this. There's been very little research into this in the cancer population, but we will definitely talk about the research that there is. So I briefly want to define resilience. Resilience is an important topic that has been studied extensively. It can be viewed as an individual's ability to maintain or restore relatively stable psychological and physical functioning when confronted with stressful life events and adversity. In the context of cancer, resilience refers to an individual's protective attributes and personal characteristics that are thought to be modifiable and to promote successful adaptation to cancer. Resilience is a dynamic mechanism that changes over time and can be affected by life circumstances, one's environments, or other situational factors. So stressful experience may cause transient disturbances, even in the most resilient individuals, which can manifest as mind wandering, sleeplessness, preoccupation. But there's marked variation in how individuals cope with cancer. And there's growing recognition that resilience to life-threatening situation is far more common than we once believed. So it's not common, but it's definitely possible. Many survivors can handle extremely stressful experiences with minimal to no effect on their daily functioning and even may experience a positive growth afterwards. In addition to biological factors or factors that you're born with or just possess, their environment and your social support play a huge role. So back to this graphic. This is an analogy that I'd heard recently that I think really encompasses it. Pretend you're in a building that is hit by an earthquake. The building has significant damage to the earthquake. So what can happen is the building just collapses and you never choose to rebuild, or you're never able to rebuild. Not choose, the choosing was not the right word. You cannot rebuild the building. Another option is that the building has some damage, but you're living in the building with some broken things and you're just surviving with impairment. Another option is that you rebuild the building, fix everything to exactly how it was before the earthquake. And then there's an option where some people are capable of having the rubble, being in the rubble, and then rebuilding it to something better than it was before, surpassing what it had previously been. And so what does it mean to thrive? So the concept of thriving is mainly used to describe those who are in one way better off than they were prior to the trauma. Post-traumatic growth is a concept or term that was coined in the 1990s, but has gained a lot of traction over the past few years. I first learned about it when I was attending a survivorship lecture as a patient through my hospital, and it really kind of sparked something in me that then forced me to read about it and learn about it and then talk to people about it. It's defined as a positive change experienced as a result of the struggle with a major life crisis or traumatic event. It is not uncommon, but it's certainly not universal. In fact, most people who have a trauma don't have any positive growth afterwards. But I think knowing that there's a possibility and can maybe shape the way we think about it so that we know it could possibly happen for us. So post-traumatic growth is obviously difficult to quantify and it's difficult to study. And I'm not saying that any of you should be feeling the need to find growth or find a silver lining. Not everything, this is advice that I got when I had cancer, not everything has to have a silver lining. Cancer can just suck. Certain aspects of cancer just suck. There is no silver lining. There does not have to be some positive meaning that we make of it, and that's okay. And so I want to validate that as well. And along with that, we need to be aware of toxic positivity. This plaque here is from an actual cancer garden at a Chicago hospital. And I think it's the imperfect encapsulation of what we call toxic positivity. The plaque says, make up your mind that when your cancer is gone, you are through with it, which both as a cancer survivor and an oncologist is a ridiculous statement. And so toxic positivity is that implicit or explicit pressure to stay positive in the face of profound adversity. Toxic positivity can be self-imposed or can be caused by external pressures, such as friends, family, or medical professionals, or plaques in cancer gardens like this one. The reason it is toxic is because it leaves little room for the perceived negative thoughts or negative feelings that are absolutely natural to have when you're going through trauma or through cancer. A big concern with this belief system is that it denies human emotion. It can also lead to isolation. If you're not feeling supported and validated when sharing negative emotion, you're going to feel isolated. Toxic positivity is also harmful because expressing your negative emotions and thoughts is not only good self-care, it's actually crucial for your mental health. There was a Stanford study that was done over several years that found that denying negative feelings as a coping mechanism was linked to higher levels of depression. Another study found that people actually felt sadder when they were expected to not feel any negative emotions at all. So definitely stuff to note. So there's 5 generally accepted aspects of post-traumatic growth. The first one is personal strength, which is characterized by increased resilience, self-reliance, confidence, and increased authenticity. Another is an appreciation for life, which can manifest as increased gratitude, altruism, and a clear sense of priorities. Spiritual growth is the next domain, which is when one develops deeper beliefs and awareness and clear sense of purpose. This by no means has to be religious, but it just a general sense of spirituality. The fourth domain is improved relationships and increased sense of belonging, increased vulnerability, and increased empathy. And the fifth domain is new possibilities or new interests and perspectives. This is an adaptability and openness to new ways of living and working. So there are 2 traits that appear to make someone more likely to experience post-traumatic growth. One is openness to experience, and the other is extroversion. I am not an extrovert, so there's clearly a workaround to all of that. Openness to experience is believed to be an advantage because people who are more open are likely to reconsider their belief systems. Extroverts are more likely to be active in response to trauma and seek out connections with other people, such as what we're all doing here. And this is where support groups and cancer friends come into play. Gender and age may also be factors, but not such big factors. Some studies have shown a small but increased effect that women tend to experience more post-traumatic growth than men, but it's very tiny effect. And also a small effect that younger patients may be more able to have post-traumatic growth. So can we set ourselves up for post-traumatic growth? Yes, we can. Traumatic events alone are insufficient to cause post-traumatic growth. You need to have the ability and desire to sit and heal, sit alone with your experiences, and to reflect on it and to seek to find meaning in them. And if some people in this audience are support systems or caregivers, we all know people who are going through cancer or going through something traumatic. It's important that we don't just jump right into telling people about post-traumatic growth. Again, that can be seen as toxic positivity, and you don't want to be construed as minimizing someone's pain or suffering. You also want to be careful not to bring up this topic until a person kind of broaches it themselves. And you want to wait for someone to express some sort of positive reaction. So again, let's talk about the science. Let's talk about what we can be doing to enhance post-traumatic growth. So here briefly are the details of a scientific study. The purpose of this study was to investigate which coping strategies were associated with post-traumatic growth and well-being. This study included women with breast cancer who were undergoing their primary treatment. The investigators of the study used questionnaires to obtain information on patients. One of the questionnaires is the proactive coping inventory, which assesses different coping strategies, and the other is the general health questionnaire, which also just assesses general symptoms. So some of the questions in it are rating yourself. The first question here is, I am a take charge person, and you say yes or no. Then on the general health questionnaire, it's questions of, do you feel like you're in good health? Have you felt that you are ill? And so putting this all together, you get a score. And so the results of this study showed that proactive coping, as well as other coping mechanisms, emotional support seeking, and even avoidance coping, were positively correlated with post-traumatic growth. Proactive coping means dealing with the stressor before it's actually happened. This is where, again, where cancer friends and support systems come into play. If you listen to your healthcare team or your friends that are telling you symptoms that could come up, and then you talk to people who've had whatever disease you've had or whatever symptoms you might be having, it can actually help you increase your ability to grow through that. So this is in contrast to conventional coping, which is dealing with the issue once it already comes up. So proactive coping is directed towards the future and includes efforts to promote challenges and personal growth. I want to highlight this finding from the study, which is avoidance coping, which essentially involves doing nothing, essentially. This was shown to be a factor affecting post-traumatic growth. Avoidance is usually thought of in a negative light, but in this study that we were just talking about, they found that avoidance coping was correlated positively with post-traumatic growth. There are reports that avoidance coping, or just distracting yourself, reduce stress and can be adaptive depending on how it's used. Immediately after the traumatic event, there's this process of automatic intrusive thinking and rumination. In previous studies, avoidance coping has been reported to have the ability to minimize psychological stress responses through mood relief. So in light of these findings, it's necessary to reassure ourselves and our friends and our loved ones that avoidance may be beneficial. So all of the mindless scrolling on Instagram or Facebook, watching silly TV, anything like that that kind of helps you not think about it is actually beneficial. With the caveat that eventually you will have to sit down and do some reflection on the traumatic event. But reassurance that avoidance is definitely good in certain situations. So the title of this slide may seem a little paradoxical. Can increased stress levels lead to post-traumatic growth? The answer is both yes and no. There was one survey study that I reviewed that they assessed people with cancer at 5 different time points: at diagnosis, 3 months into treatment, 6 months into treatment, and then during survivorship at 12 and 18 months. The study was investigating both the impacts of distress and stress at diagnosis and to see if it predicted post-traumatic growth at 6 months later. What the authors of the study concluded was that global stress, so stress about everything, so stress about finances, family, other people, just life, was negatively correlated with post-traumatic growth. But cancer-related distress, so distress about your current cancer, actually increased your likelihood to have post-traumatic growth. And so the authors of this study concluded that the greater the cancer-specific distress was, the person experiencing it was more likely to focus their energy and search for meaning and search for growth opportunities, whereas a general background stress kind of took away from that ability and distracted the person from kind of reinventing themselves and finding meaning. This study also shows that 6 months after cancer is kind of a pivotal time for post-traumatic growth. And this is usually the time where your treatment's first ending and the initial stressor is kind of fading and you're starting to see an end in sight. And so that's definitely important for us to make note of. Another interesting finding in the study was that post-traumatic growth actually decreased rates of global stress. So people who did experience post-traumatic growth reported much less stress in the future. So it kind of changes everything in the way people feel. So again, are there things that we can do? Are there things that we have the ability to change? I don't want to discuss this one study. So in this study of almost 2,000 patients, they responded to questionnaires at 2 and 5 years after the diagnosis. Factors that were found to be associated with moderate or high post-traumatic growth were: 1, being satisfied with the time spent by their healthcare team on the information that was given, and 2, increased activity and healthier diets, which is why your guys' activity in the beginning really, played into this talk as well. We obviously know that diet and exercise are modifiable, so these are actionable. And we know that these are good diet and exercise are cornerstones of cancer care and healing. So while it might seem annoying when people are nagging you to eat better or do more exercise, it definitely has been shown to increase so much about our cancer survivorship. Another factor that may not seem like it's modifiable is satisfaction with the time spent by your healthcare team answering questions. If you feel confident in your healthcare team and the information that you're given, this will lead to the patient having less anxiety and depression. So it seems that information plays a very pivotal role in regaining control in the face of something that is seemingly uncontrollable. This is where the reason I'm bringing this up here in this talk is that this is where choosing a doctor that you trust and feel comfortable with is key. I always tell my patients and any patient or friends, anyone, that if you don't feel comfortable with your doctor, go for a second opinion. This is vital to your care. You have to feel safe with your doctors and your medical team, and you want to trust that they're giving you all the information. So a common misconception is that post-traumatic stress disorder and post-traumatic growth are on two opposite ends of a spectrum. This is an older graphic that I'm putting here, but that's not the case. As we discussed earlier, there are studies that have shown that growth is an adaptation in those who experience stress following cancer diagnosis. And this may suggest that stress initially increases your ability to have post-traumatic growth, but may also hinder it if the stress becomes too severe. So you want some stress, but you need some kind of, because you need something to kind of give you a reckoning, something to force you to really contemplate what's going on, what's happening to you, what's the meaning of any of this. But then you don't want too much stress because it might interfere with your post-traumatic growth. So it leads us to conclude that post-traumatic stress and post-traumatic growth are not really opposite ends of a spectrum, but a complex web of things. So this slide is showing data from a study that was aimed to develop a post-traumatic growth program. There were 74 participants enrolled. Half were in the post-traumatic growth program, and half just went about their day in the way that their oncologist told them to. The half of the patients who were in the experimental group were enrolled in a program that involved doing writing and self-reflection for self-analysis, talking, sharing, self-disclosure, and participating in self-help and healing groups for social support. The program also taught meditation. Here on the left is the program. It's probably small to read, but the first session there was you learned how to journal, you learned how to meditate. Sessions 2 and 5, you came with your journal, you talked about it in the group. And then the last session, session 6, was a summary and you went over all the results. So what they found in this study is that the group that did the experimental intervention with the talking and the meditating and whatnot had lower emotional distress scores, lower intrusive rumination, and higher deliberate rumination, meaning time to deliberately sit and think about what they were going through. But that rumination was kind of in their control. So this gives us proof of concept that post-traumatic growth programs have an ability, well, one, that post-traumatic growth programs can exist, and that they have an ability to contribute to the promotion of post-traumatic growth in people with cancer. This was also a very interesting discovery when I was delving into this. We all know that the internet can be a really scary place. There's just so much information. There have been actual studies that show that post-traumatic stress symptoms are positively correlated with the amount of time spent looking online for cancer-related medical information. So this leads us again to conclude that post-traumatic stress symptoms, so the bad symptoms, are linked to the perception of being inadequately informed about your illness. However, post-traumatic growth is positively correlated if your search is predominantly about psychosocial information rather than actual medical information. So if it's a mental health, well-being, you'll actually have more ability for post-traumatic growth. So as a medical provider, one way that we can seek to improve this is by filling in the gaps, making sure the people I come into contact with have all the information we need so that they have all the time to delve into the psychological and psychosocial aspects of the internet. So the internet definitely has its place in cancer care for sure, and this study blew my mind. So the conclusions of my talk are that cancer is a form of complex trauma. There are interventions that may help us grow, and that it's necessary to develop programs to increase post-traumatic growth and to deal with PTSD. And, this quote kind of shook me the first time I heard it. I feel it really hits the nail on the head of why we have to do this work and why we talk about these things. you're not healing to handle the trauma. You already know how to do that. You're healing to handle the joy. And so we could sit in our trauma, and most of us will and can, but we really need to find a way to just find a little bit of joy in every single day. And it's sometimes it feels impossible, but I mean, thank you for coming to this talk. I really like appreciate that you have lent me your ears. This quote up here is from a book that I read recently. The book is not about cancer, but it was a quote that resonated. Strange how suffering can look beautiful if you get far enough away. And what that meant to me was I would give everything right now to go back and to never have had cancer, to never have had that experience, to never have this knowledge. But I also simultaneously can acknowledge that it's made me a better person and that I've fundamentally and changed completely in ways that some of them are good. And so now I would love to answer any questions that you may have.